Welcome. Today's webinar is part of our virtual annual meeting event. It is now my honor to introduce the moderator for today's program, Dr. Paul Halverson, the founding dean of the Indiana University Richard M. Fairbanks School of Public Health, Indianapolis, and the chair of the ASPPH Practice Advisory Committee. I will now turn the program over to Dean Halverson.
Well, thank you, Rita. I appreciate being able to moderate this fine panel this afternoon, and let me say thank you and welcome to all of my colleagues. This is unprecedented time, and this is also a time to learn, but it's also a great time to, if you can, on Zoom, just reflect back a little bit, and this is a time to create our own community. So thank you for being with us today. And it's great to have the opportunity to moderate this session, which is developing and delivering training for critical skills for the public health workforce. And I would just say, in part, this is an opportunity for us to talk a lot about practice, which is one of my favorite subjects. And as you may know, I chair the practice committee for ASPPH, and it's a shameless reminder that I think practice is a pretty important part of our work. Certainly not the only part, but I think today it's really where the rubber hits the road, and we'll talk a little bit about this. So today I am pleased to be joined by three incredible colleagues. First, Dr. Trudy Larsen, who is the founding dean of the School of Community Health Sciences, University of Nevada, Reno School of Community Health Sciences. Also, Dr. Robert Wyler, Associate Dean for Academic Affairs, College of Health and Human Services, George Mason University. And my colleague, Dr. Paul Irwin, Dean and Professor at the University of Alabama at Birmingham School of Public Health. So today you'll have the opportunity to ask questions, and just as you probably are, we're all kind of in this rhythm now with doing these large Zoom calls. So you'll have an opportunity to ask questions by clicking on the Q&A button at the bottom of the screen, and we'll hold questions until the end of the presentation. So I have a few things just to sort of set the context, if you will. And if I can figure out a way to, could someone help me with my slides? I'm sorry. You'd think that after 8,000 Zoom calls, I would know how to do this. So, okay, that's the Q&A. The next slide, please. Okay, so just a reminder, we never want to let an epidemic pass us by without leveraging it for good. And again, we know that this is a terrible time in our nation and our world. And so as a consequence, there is an opportunity, though, that we needn't forget, and that is that this is a great time to remind everyone of why we need public health. And it's I've already had incredible opportunities to talk with our governor and to talk with a number of our policymakers around why public health is important, and in particular, the importance of funding public health infrastructure. And take it from me, you don't often get that opportunity. And so don't let a good crisis pass you by, and just a word to the wise. And I also would tell you, at least in these times, public health practice is where the rubber hits the road. And sometimes I feel like that guy trying to maneuver these four unwieldy tires and hoping that we'll get to where we're going. And that's part of what I hope that we'll talk a little bit about today, was take advantage of the opportunity. What has this crisis taught us? And for those of you that were with us in the Deans and Program Directors meeting yesterday, we started that conversation. What are the skills and things that are skills, and what are some of the opportunities that present as a result of our crisis? But here's just a few things to think about as we consider it. I thought about the work that we do in supporting state, local, tribal, and territorial health departments. I've heard a number of things from colleagues all over the country. It seems to be a lot of work that's going on in disease and surge modeling, testing. And again, we're getting ready to start both virology and serology, a random sample testing that's going to be going on in our state. And that's really very exciting. It's also an important opportunity to talk with folks about the difference between clinical testing and population health testing and why you need both. Contact tracing, exciting things going on right now in public health. As we're seeing so many of our schools and programs in public health that are stepping up to take important roles to support public health departments at a state and local level in terms of contact tracing. And as we look at new legislation that's being proposed around doing more in contact tracing, I think that's really great. And then there's this just-in-time training that I think we in public health need to remember, that we've got a lot of courses, but we also have huge needs for people in service who have particular needs that we can, in just-in-time basis, perform and provide some of the training issues. And then evaluating our current curriculum in light of current reality. It's kind of hard to imagine that we could do one more thing in these crazy days. I don't know about you, but it seems to me that there's just so much more to do, even when you're doing it from home. But evaluating our current curriculum in light of the current reality, I think, is really an important opportunity that we can't miss. Assessing critical gaps, I'm talking with our alums, and I'm talking with our colleagues that are in state and local public health incident command, and I'm hearing what are some of the things that we could do a little bit better, and particularly around teaching incident command and preparedness skills. And then this whole notion around skills, and it's important to marry our theory to practice, but it's also really important that we consider the skills that may be in deficit and that may need supplementing as we move forward. And as far as IPE goes, this is a perfect time to make the case. If you've had difficulty in the past about making the important case for interprofessional education, I think today is really a great opportunity to drive that home in terms of why we all need to be working together. And then last, let me just say there's incredible opportunity for advocacy and joint efforts that I think create, again, this marvelous opportunity to talk with policymakers about why public health is important and what schools and programs in public health can do to help support the state and local efforts. So let's move now to our first speaker. Next slide. Please join me in welcoming Trudy Larsen. Dean Larsen is the dean at the Reno School of Community and Health Sciences. And Trudy, we're interested in your presentation, so please proceed.
Excellent. I need to get my video going again. There we go. All right. So it's wonderful to join you today. It's still morning here on the West Coast. And so we are going to talk today about our process of discovering what our workforce needed locally. We do a workforce development survey on a fairly regular basis. And the reasons we do this primarily, well, actually they're twofold. One is because this is part of our deliverable for our Public Health Training Center grant. And we do this in conjunction with the rest of Region 9, so Arizona and Hawaii and California. And we have a very similar survey, but we can add specific things to our survey that we do with our state. So that's one reason. The other reason is we have used this workforce development survey to really look at our curriculum and understand what other things we should be adding, what can we subtract. So it's been very helpful for us in looking at curriculum. And then lastly, we've had excellent participation around the state because the health departments are going through accreditation and they need this information as part of their accreditation process. So the format of the survey that we used is an online survey. We used Qualtrics. We had it open for 1 month. And this survey took about 20 minutes to complete. I completed it, so that's really about right. There were approximately 80 questions that depended on the tier, and I'll explain that a little bit further in the next slide. But we used a Likert scale to assess how competent people were in these various skills. And so level 1, none, very little, 2, beginner aware, 3, competent, 4, proficient, 5, expert. And so that's how we looked at the responses from the participants. We also used, we assessed if they would be interested in taking a semester-long course. We used our courses at UNR to really look at what they might be interested in. And then we also looked at their preferences for educational format. So we used the traditional tiers of the public health professionals, managers and supervisors, directors and senior leaders, and we added support staff. And the reason we did this is I think we all recognize that the first person that somebody might come to meet is often at the desk, and that their competencies are very important in terms of being able to work with vulnerable populations or make sure that that welcome is warm and inviting and allows for a better delivery of services. So here were the core competencies. You should be really familiar with these by tier. And so we looked at cultural competency, communication, community dimensions of practice, analysis, assessment, public health science, financial planning and management, policy development, program planning, leadership and systems thinking. Of course, these are the tiers that have been well developed through the Public Health Foundation. And then we added some general office skills for the Tier A group, just to assess any of their training needs as well. We had an excellent representation. We had 810 participants. The reason we had those kind of participants is we had enormous buy-in from our health districts. There are 4 in Nevada, Southern Nevada, Washoe County, Carson City, and then the state is responsible for the rest of the relatively rural and frontier areas of the community. And so they were encouraged to participate, and they did. The demographics should not surprise you. We had age within the majority in the 45 to 59, primarily white. This is fairly representative of our population for the most part. We do have a sizable Hispanic Latino population in Nevada, and this is not representative of that. Interestingly, most of these have been in the field for a very long time, and they've been with their organization for a very long time. And they're primarily female, also not a surprise. We asked their degree completion, and the majority had bachelor's degrees, but it's also, I think, impressive to understand that we have associates, we have non-clinical doctorates, we have clinical degrees, a whole variety of other degrees that may not necessarily be public health degrees. And so, as I'll show you the results, there was a fair amount of lack of competency in many traditional public health fields. 51 of the respondents were public health professionals. We would expect that. These are our frontline workers, our contact tracers, folks who run the immunization programs. And so we were happy that we saw this particular group really respond to this survey. Sorry. All right, I'm not going to go through every tier and show you the results, but I'm going to give you a snapshot of the public health professional tier. And the means that you see here are actually the very light gray circles. And then you can see from the various health departments where people fell in terms of their competency. But it's very clear that in financial management, public health sciences, this is epidemiology, biostatistics, and some policy development, that there was some need for training. I keep going back, I'm sorry. Here's how they decided they wanted their training priorities. You can see where they overlapped: leadership skills, organizational behavior and awareness, a critical piece of that COVID response in terms of ICS, quality improvement, and their supervisors selected the same things. The majority wanted to have, would choose an organizational behavior semester course if they could do that. And with this data, here's how we've used it. For the working professionals, we've developed targeted educational programs from the training center with health district input and request, so very much targeted to their populations. With the overall needs, we've also constructed a number of web-based educational programs, again, targeted around the competencies that folks felt that they didn't really meet a level that they required. And we're creating online certificate programs. We just got those approved through our curriculum committee, again, based on those identified needs. And for our curriculum, we now require organizational behavior as a core course for our master's program. And we've also put additional competencies in for quality improvement and leadership in other parts of the curriculum, and really strengthen assessment of these competencies to identify if they're really being sort of embraced and understood.
Okay, I think I'm on. Hello, everybody.
Yes, I'm sorry, Bob. I made a fine introduction, but you missed it. Everybody did because I was on mute. Sorry about that. Let me introduce Bob Wyler, our colleague from George Mason, and it's his turn to present. Thank you so much, Bob. Sorry for that.
No problem, Paul. Thank you. Let's see if I'm ready to go here. I think I can move. Here we go. Yes, I just want to, good afternoon, and I think my presentation is going to braid well with Trudy's presentation, and what I would like to do is provide an overview of the Mason experience and how we have evolved from our MPH program in order to deliver training for critical professional skills for public health. In terms of background, I want to talk about where we started and some of the drivers that informed the changes that we have made and kind of the evolution of our MPH program from, the classic 5 pillars to a more practice-based focus program, and also some recent workforce development partnership that are in line with what we're trying to do in public health practice and some lessons learned. By way of background, the Department of Global and Community Health at George Mason University is pretty young. We were established in 2006. Currently, we have a CEF accredited BS program in community health, an MS in global health, and an MPH with 7 concentrations, and you see the approximate enrollment there. We also have a graduate certificate in public health, and we have a PhD in public health that's under development, which is going to have 2 concentrations in epidemiology and 1 in social behavioral sciences. We currently have about 20 full-time faculty with 14 primary instructional faculty, 10 affiliate instructional faculty, and a number of adjuncts as well. Where we started, I came on board as the department chair in August of 2014. And at that time, we had 2 concentrations in epi and global and community health, and we had a 21 credit core. And you could see there on the slide that it pretty much mirrored the standard pillars of public health, with probably the exception of project management in public health. So over time, we knew that we wanted to make some changes for a number of reasons. One, we wanted to kind of move to more practice focus, but also we had grand plans of transitioning to a college of public health. So we knew that we had to build out the number of MPH concentrations that we're going to be able to offer. So within about 4 years, we went from 2 to 6 concentrations, including 1 in health policy, 1 in public health practice that's going to align with our mission, and then 1 in public health communication. The 1 in health policy and public health communication are affiliated with 2 other departments, 1 within our college, but 1 outside the college. And we went from a 21 credit core to an 18 credit core program. Some drivers informing the curriculum modification was 1, the changes to the CEF criteria, and that we were fast approaching reaccreditation, and we were embarking on a CEF reaccreditation self-study. Throughout that process, we did a number of things to collect information. Certainly, we tried to inform decision based on the literature and looking at what thought leaders in the area of public health practice had to say in terms of skill demands. We looked at our regional market and Fairfax County. George Mason University is located 14 miles outside of DC. So we have a large metropolitan area that serves a number of different employment sectors. And so we wanted to see what was the jobs, what were they seeking? What were the employers seeking by way of competencies? And then we were looking at our contextual stakeholders in addition to our primary professional communities, but we wanted to see, again, what our employers were looking for and in our graduates. And then another driver was our advisory board. We have a very robust advisory board that includes a number of public health professionals and public health units. We have a person from the Department of Homeland Security on that board, someone from Northrop Grumman, ICF, the Kaiser Foundation, and a large health system. We have just broad representation. And so we engage them in a number of different conversations over a period of about a year. And we call them the advisory board critical discussions. And we wanted to look at what are the current and emerging public health issues. We asked them that question, along with what are the current trends in public health practice, and how can we ensure our students have the relevant workforce skills, and what are some novel ideas for assessing the workforce needs of our primary communities outside of conducting a survey, so to speak. And so based on the information, by looking at a number of different sources of information, we synthesized the information, and then we started a deep dive into our curriculum. And so, excuse me. There we go. And so this is where we are now. Again, we went from more academic MPH core to a more practice focused core. We added another concentration in food security and nutrition. And then you can see how the core changes into the foundations of public health, meet those foundational competencies. We collapsed the epidemiology course and the biostats course to fundamentals of epi and biostats. And the other concentrations build upon the quantitative skills relative to each of the concentrations. We included community assessments and partnerships, health program planning and evaluation, and the like, as you can see there. So quickly, I wanted to talk about two partnerships that we have. One is with Fairfax County Health Department. The other one is with Association of State and Territorial Health Officials. With the Fairfax County Health Department, we also have a graduate certificate in public health that's offered online and in person. It's 18 credits. It has a 15 credit core with 3 credit electives. And generally, it requires 2 years of work experience in health-related field to enroll in the program. And those students that complete the program that have earned a B in all coursework, the GRE is waived so they can enter right into the MPH program. And so what we've set up with the Fairfax County Health Department was a kind of a graduate certificate just for them. And they recognize that they need to develop workforce skills in the professionals that they have. And so we started off with a cohort of 12 this year. And this is employer paid program. They take 2 courses per semester. They started this past fall. They'll end in fall of 20. And part of it, what's unique about the program, we think it's really neat, is that they are going to work on a cohort-based project, relative to a major issue or need for the Fairfax County Health Department. We have no idea what that's going to be with COVID-19. We had some ideas. I have a sense that that's going to change. And the idea, we've already planned for the second cohort for the fall of 2020. And we are looking to scale this up to the other 4 health departments in the greater DC metropolitan Northern Virginia region. I think I'm running out of time here, but I just want to hit upon, and you can go to our website and learn more about the Mason-Asto Collaborative for Public Health Practice. Mike Frazier and I have been working on this for a number of years, and what we wanted to do is kind of have everyone heard of academic public health department partnerships. We wanted to set up something similar, but with ASTO, and the idea would be totally around public health practice and workforce development, how we can train undergraduates and graduate and professional degree students, even those that are outside, those that may be in business or in law or in finance or human resources. And we have set up a scholars and fellows program where they're going to be, we're going to have selected students that are going to work with ASTO part-time while they go to school and pursue their MPH degrees. And also, this is going to provide an opportunity to have academic faculty and ASTO staff collaborative type of initiatives where they're going to work together on joint ventures to help the constituents of ASTO. The focus areas around this is, you can see here, around research, data analytics, library access, training and learning opportunities, and also we can be a fiscal agents from some small projects that are around workforce development and learning and training. And overall, here's our Mason's goals. Again, this is on our website. I just wanted to say, I think when you venture out, I think that you need to kind of be intentional, know your market. Not everyone has an ASTO in their backyard, as I'm reminded, but all programs and schools have other constituents that they can serve and help build the workforce needs of their employees. I think it's important that you engage your stakeholders and, leverage the C competencies. A lot of people, some people are critical of the competencies. I think that you just need to kind of leverage them and play to your strength in the program and the resources that you have and the faculty that you have to develop and design programs that will deliver skills and the knowledge base to your students so they can be successful as they embark in their careers. Thank you.
Bob, thank you so much. I know as an ASTO alum, I can speak for Mike Frazier and others how proud they are of having that relationship with your school, and it's just terrific. Thank you for your presentation. Next, our friend Paul Irwin. Dean Irwin is the Dean and Professor at UAB, and we're really excited to hear him in his presentation. Go ahead, Paul.
Good afternoon. Let's see if I can manage this. There we go. Good afternoon from Birmingham. It's wonderful to join all of you, my friends and colleagues from across the country. I appreciated hearing Bob and Trudy's presentations on the public health workforce and a special focus on the public health workforce. My focus will be on what we need to be teaching students in our classrooms now. So what I'm going to talk about is teaching public health practice skills and methods so that our students can do the things that Paul Halverson described in his introduction: disease investigation, contact tracing, and modeling. I think that it fits very well, and Bob, thanks again for teeing me up with the CEIF competencies. I think it fits very well with CEIF competencies. The ones that are colored in red are clearly competencies that a focus on public health skills and methods course can include. The ones colored in green are a little bit wider number of competencies that can be included in coursework that focuses on skills and methods in public health practice. Here are some additional MPH foundational competencies. Again, I think that it fits well here. So what do we need to put in place now? What do we need to be teaching our faculty, our students now? We need to be teaching public health students the methods and skills that are used in crises such as a COVID pandemic, what I'm calling methods in public health practice that I think, from my 2 cents worth, should be a part of the core required curriculum, so that we cover processes involved in real disease outbreak investigation. How do you actually do disease reporting? How do you input the data in different types of surveillance systems, including syndromic surveillance? How to actually think about crisis communications. And very fundamental to this is engaging public health practitioners in the classroom as co-instructors. So what I'm going to describe to you is a course that I was part of developing when I was at the University of Tennessee. This was developed, again, in concert with the Tennessee Department of Health as part of their CDC-funded Centers of Excellence in Food Safety. This was a 1-hour graduate course entitled Student Outbreak Rapid Response Training that went by the acronym SORT. Again, a 1-hour, 1 credit hour course that really did depend on public health practitioners in the classroom as co-instructors. So I was fortunate in having nearby the Knox County Health Department with their epidemiologist, but also epidemiologists from the central office in Nashville who joined us either in person or by Zoom. The course started out actually one day before the semester officially opened, when we were able to initiate the students, if you will, in a full 8 hours of training in outbreak investigation. Here we went through such topics as Epi 101. We introduced them to Epi Info. We had simulations and really did do a deep dive so that they would come out of this 8 hours of training oriented into what disease outbreak investigation is all about. Because one of the fundamental purposes of this training was to be able to equip students with the skills that they would need to be able to respond to surge capacity needs of our local public health practitioners in the event of a real disease outbreak. Following the 8 hours of training on outbreak investigation, we had a monthly 2-hour in-class session where we focused on skills such as questionnaire developing and interviewing, how to actually use EpiInfo, how to actually do interviewing over the phone to input data into the NED system or other disease reporting systems, and finally, how to both apply and understand and interpret measures of association such as odds ratio and relative risk. We also had each time outbreak investigation updates from our practice partners, including the EIS officer who was posted to Tennessee. We also did a 1-hour journal club weekly, in which we had students presenting different ongoing outbreaks across the country. Students were required to complete 2 certificates related to the incident command system. With the local public health departments, they went along on restaurant inspections to get a firsthand feel for what that involved, because restaurant inspections are always a part of foodborne disease outbreak investigations. And at the local health department, they were involved in routine disease reporting. So all of the routine things that happen when a pandemic is happening at the same time. And as a part of their service learning aspect of this course, they were on call for surge capacity for the health departments and actually did get called in to provide assistance when we had real disease outbreaks during the time of the courses. With this kind of public health practice skills, these are the things that students can be equipped to do now, even while they're still students. And I know that many of you, many colleagues across the country, have students involved in doing these things already: contact tracing and disease reporting, staffing a phone bank, doing active surveillance regarding ICU bed and ventilator availability. I'll just add, getting back to Paul's opening comments, things that our faculty can be doing now, and in many places I know are doing, serving as a think tank and a sounding board for evidence-based decision-making by governmental health officials, analyzing early information to provide profiles of positive cases that are emerging locally, and then creating, disseminating, and analyzing information in real time about how people are following, for example, health department orders to stay at home. What do we need to put in place now so that this is all facilitated in the future? A mechanism that provides a bona fide health department appointment for certain key academicians. This is the academic health department model. Mechanisms to alter or suspend certain requirements in order to allow students to work with disease reporting. And again, getting back to Paul's opening comments, let's use this moment to advocate for a return of federal funding for emergency preparedness and response. So with that, I'll close, and we'll look forward to any comments, questions, and discussion that we might have. Thank you.
Well, thank you, Dean Irwin. It's wonderful to be able to introduce you, by the way, as Dean Irwin. Paul and I have known each other for decades, and I think in many different roles, both of us. So it's wonderful to have you as a colleague at UAB. I think all three of the presentations that were made today were really on point. Important things for us to consider. So at this point, we'll begin the question and answer portion of the webinar. One question we always receive is whether a recording of the session will be available. And you might not be surprised to hear the answer is yes. The recording for this session will be available early next week, and you can also access recordings of the ASPPH virtual annual meeting sessions at the web address on the slide. So again, if you have questions, you can click the Q&A button on the bottom of the screen, and we will answer as many questions as possible during the remaining time. So at this point, let's start the panel discussion with the burning question that I think we all are interested in, and that is, what skills do we need to be teaching our students to prepare for future pandemics? You know, this won't be the last one, and in fact, I think we are all pretty certain we'll see something in the fall that will be with us again. So what is it that we ought to be learning from now that we can take forward that will help our students? And I think a few of us mentioned some things already, but let's just, each of you mention a couple, and we'll go around. Would you like, let's start with Bob, if that's okay.
Yes, I think some of the tried and true competencies are always going to be relevant regardless of the outbreak or a public health emergency. And that has to do with leadership and certainly having a solid background in technical skills and grounded in the fundamental knowledge of public health. And I think the leadership skills, communication skills, crisis management skills are going to be essential moving forward.
Great, thank you. Trudy.
So we have a very large undergraduate population. We have well over 2,000 students in our undergraduate program. And so I've been thinking a lot about how we can prepare them to be the next workers. And so for us, it's really about disease investigation. They really don't understand everything about that. They get a preliminary in their introduction to public health, but I think that's a skills course that would be excellent, giving them, you know, a full course, the background and how you ask questions and why we do that kind of work. And then the second one is a real excellent fundamental, again, for our undergraduate students, about surveillance and the epidemiology and what curves look like, and being able to really understand. I mean, I think most of us are watching our dashboards every day for cases and hospitalizations, and for them to have an extreme grounding in what that really means and the validity of the data and about rolling averages and not daily variation. I hear these questions all the time, and I think it's really critical that they feel extremely competent in those as undergraduate.
Excellent. Thank you. Paul, before you start, let me just say I want a copy of that syllabus for that 1-hour course that you did for SORT. I think it's right on, spot on. But go right ahead. What are some of your ideas for that?
Sure. To add to what Bob and Trudy said, interviewing skills. How do you actually interview a contact over the telephone to get the right kind of information? A second skill, crisis communications, what I might describe as high risk, low trust communications.
Very good. I guess I would add as the moderator, emphasizing, as Paul did, the incident command, because we have certainly seen in this period of time that just either they didn't take it or they forgot a lot about it because it's they realize now that that's something that's so important, perhaps more important than they thought earlier. Okay, so let me just ask Trudy, based upon the results of the training needs assessment, what do you see as the top priorities for training right now?
So right now is really about emergency management skills and understanding ICS, and on the front line with the frontline workers. They haven't been through this, and this scares them. And it's also, I mean, I have to reflect on the fact that we have such an inadequate public health workforce that they have to be multidimensional. And so the other part of this is understanding organizational behavior. I mean, that came out clearly, but really understanding how they interact with people, who's got the lead, how that all works through, and what their roles are. I hear a lot of anxiety about people, like they don't know what their role really should be. And I think clearly we need to do a better job.
Certainly agree. Thank you. Bob, we're seeing that there's a need for workers to be lifelong learners. What options can our practice partners offer to employers?
Good question. And that's an excellent question. I mean, one of the things that we're trying to do early on with our students is trying to develop a relationship with them so they can understand that, well, let me backtrack. Let me say that we need to view our relationship with students as lifelong learners. That they're just not going to be in the class for 4 years or 5 years as an undergraduate or 2 years as graduate students, but we need to develop a relationship with lifelong learners. But, you know, I think that working with public health departments, you really get a sense as to what the skills that they need, the knowledge that they need in real time. And so it's always interesting that some of this stuff, and I didn't get to mention, is that all this information, our partnership provides us with a real-time natural feedback loop of some of the skills that they need in a very dynamic public health state, and to be able to respond quickly with courses, with webinars and seminars and certificate programs, and now looking into micro-credentialing programs is part of this, trying to develop relationship as lifelong learners, and our programs being a mechanism where they can learn new skills quickly and in a very efficient manner.
Thanks, Bob. Paul, students, faculty, and staff from schools and programs of public health are partnering with public health departments and other community-based organizations around the pandemic. And not all of them have a strong existing relationship for sure, but do you have recommendations on how we can incorporate the lessons learned during the pandemic to inform teaching public health across the country as we look at all of our programs and schools?
Thanks, Paul. Thanks for the question. I'd say first and foremost, invite the public health practitioners as a co-instructor in the classroom. We underutilize their knowledge and skills and their practical application of the things that we do teach. So I think that's fundamental to this relationship. Offering students opportunities to do internships with practitioners is a second area of engagement. And then third, providing faculty who can work with public health practitioners in making efficient use of large amounts of data.
Well, and this has all been very enlightening and I think helpful as we think about the future. One of the questions that came in from our colleague Joel Lee, and he said there's been estimates of the need for thousands of contact investigators very quickly. What strategies might you suggest to address this short-term demand, including both current students and others? And I know there's a lot of questions about this, and I know students are from a lot of different disciplines are being asked to be considered in these roles. So how do you all feel about this?
Well, I'll jump in on this one. I was on a call just before this one with the Alabama Department of Public Health addressing this very issue. I know across the country, we have, whether they're in the schools of public health or associated with schools of public health, we have various what I would call survey research units that do things like BRFIS, PRAMs, and similar kinds of activities. Those are workers who are primed to be shifted over to doing contact tracing, even for the short term. Those are usually not students, but they're very often right now, they may be the very workers who are sitting at home unable to work from home and could come in as essential workers to your facility. For students, we are getting students to our local health department because they can go on site there, practicing social distancing, but being trained on site. But there are challenges there because they have limited number of hours available.
So in Nevada, we have a medical corps of volunteers that has become very robust with COVID. It's almost 1,000 practitioners in various fields. And so we're really looking at potentially, especially nurses, who we could do a short training period with, and they would be able to do the tracing remotely on phones. And so I think that's another untapped reservoir of talented folks that we could turn into contact tracers.
Bob, your thought?
Yes, I'd say the same thing. We have a similar program that they have in Nevada with Fairfax County Health Department, but I think that certainly we can leverage our undergraduate students and not only in public health, but in nursing as well as social work. Undergraduate social workers have a tremendous amount of skills, especially in communication and trust, which is very important when you're asking individuals certain questions related to where they've been, who they've talked to. And so I think that going back to look at your own specific areas, your institution, the community in which you live in and you serve, is to think creatively about the type of people that you can bring in, provide some type of quick training like Paul described, and get them out in the field.
That's a great point. So let me just turn, Paul, you had a question from the audience today. The question is, how might you modify the experiences and skills for an undergraduate population in your 1-hour course that you described?
Yeah, thank you for the question. I would say that 90% of the course material and the work that's done in that course is certainly fine for an undergraduate student to do. I don't think that that there's any reason why a bright undergraduate student can't do that same kind of practice-based course.
by the way, I was in contact with our Dean of Social Work just yesterday, and increasingly we were talking about the fact that in many of the circumstances around contact tracing, having good motivational interviewing skills is one way in which one skill that's really useful. And the idea of working with social work students came up as a potential possibility. So I think there are a lot of opportunities for us as we think about how we can expand from an interdisciplinary perspective. And speaking of that, there is a lot of opportunity, I think, for us to expand and think differently about our curriculum. And we've talked a lot about perhaps how our curriculum could change, but how could our curriculum change, and how might we think that other curriculums in medicine and nursing and other professional schools, what opportunities exist because of the pandemic that potentially would open some doors for us to think about new and different kinds of collaborations, particularly in the area of curriculum? Anyone?
That's a great question. As I've reflected on this, our nursing students, social work students, our public health students, all in the master's level, medical students, just had a 2-day IPE in a virtual environment that used a case, and it's about COVID. And it's an interactive at the table. It's a real interesting process that they go through. And they haven't done this before. And so I think what needs to happen with our sister health professions is that we need to do teamwork. We need to practice teamwork. They need to know what we do. We need to know what they do. And so if we're looking at curriculum, I think we begin to introduce the other disciplines and what their role is in a team.
Good point. Bob or Paul?
Well, I think anytime you're talking about other professions, I think it goes, back to IPE opportunities. Is the more that we are engaged professionally on working on problems, I think that it will emerge that we have more in common professionally than there are differences. And I think there's nothing like solving a critical problem where people can get together and work together to try to find solutions to those problems. And so I think anytime that you can pull people together and working as teams and to be able to communicate is good for all the disciplines and all the professions.
Yeah, I would just add that it's been an interesting time to have medical students, especially 3rd and 4th year medical students who, at least here in Birmingham, have for the most part been sent home, to have them involved in contact tracing. And so now they're working alongside public health students at the local health department doing contact tracing.
Well, that's a great opportunity. I would say from our perspective in our IPE, we actually have four pillars as we describe them, and all 4 pillars must be taken by all of our health profession students taking the course together, if you will, and doing simulations or case studies together. And Trudy, I think it really is an issue of helping, initially at least, understanding what each profession brings to the table. And it's always a big aha moment for, I think, all of our students to understand what each other do and what they're capable of doing. And Paul, to your perspective, we also are working with our medical students. In fact, we're collaborating on a course on COVID care, and we're going to be co-teaching it with the medical school for all of our 3rd year students on the role of public health, what public health is, and modeling and contact tracing and so forth. And then for a number of our medical students, because of the same issue you've described, they're out of the clinic for a while. In fact, we're delaying the clerkships. And so a number of students, we're going to provide an opportunity for an expedited admission to our MPH program. So we expect about 30 students or more that will be part of the MPH in an accelerated program for this year. So there are opportunities, I think, for all of us to think about ways to work with colleagues in this time. So let me just open it up for any last comments, just a word or two from each, if you wouldn't mind, and then we'll close it up. And thank you again.
So I'd just like to say that the workforce development survey that we do every 3 years is a lot of work. But I believe that it helps us engage with our community in a real significant way, because we are helping them in identifying the needs of their workers. So it has helped us bring more engagement and really looking at what courses and what kinds of things that we're going to be presenting to them. And so it has been, even though it's a lot of work, I think it has paid off over and over and over again. And I think we are preparing a better workforce, particularly for our local community, but they're common skills. So I'm hopeful that they can go wherever they would like to go.
Thanks, Trudy. Bob?
Yeah, I would just add to that is try not to reinvent the wheel. There's a lot of good programs out there. We've got a nice community of colleagues in ASPPH. Out to your colleagues and trying to figure out what's worked, what hasn't worked, what are the lessons learned. And I go back to trying to be intentional and thoughtful about what you're trying to do, what you're trying to accomplish. And like Trudy said, engage your stakeholders and know the community that you're serving. And don't be afraid to try something different and something that's out of the box, and really try to use the SEEP competency, trying to leverage them to the best that you possibly can, so you can craft programs, certificate programs, seminars, webinars, micro-credentialing, whatever it is that will resonate with your body of learners in your institution.
Thanks, Bob. Paul?
Sure. I don't usually like to make war analogies or metaphors, but marksmanship is a fundamental skill that is practiced by every soldier in training, regardless of whether that soldier will ever fire a weapon outside of training. I think we need to take that same approach regarding the teaching of these kinds of public health skills and methods to our students, to all of our students.
That's great. That's a great analogy. Let me say thank you to all of our panelists today. I think it's been an incredible presentation, so thank you so much. Before we end today's webinar, a few notes. After the close of the session, you'll receive a link to the evaluation. Please take a moment to complete a very brief session survey. The Zoom will display it on your web browser. Next, since the coronavirus disease COVID-19 was declared a public health emergency, ASPPH and our members, the schools and programs of public health, have been collaborating with public health departments and other community partners to respond to the pandemic. ASPPH launched this hub to share information and resources. In addition, the ASPPH weekly newsletter, the Friday Letter, is now featuring the latest news about the novel coronavirus. And finally, here's a list of the virtual annual meeting sessions coming up next week, which you can learn about more and register on the ASPPH website. Please visit the ASPPH website for information on these programs. So this concludes today's webinar. Thank you all for joining. And finally, I want to thank all of our panelists for sharing your expertise and all of you for your attention and thoughtful questions. A recording of this webinar will be available shortly on the ASPPH website. Additionally, ASPPH has compiled resources and guidance from our member schools and programs of public health as they respond to the COVID-19 pandemic locally and globally. Thank you.